introductory session. Okay, so this is introductory session. So in this session, what we will do, regularly weekend classes, 2 hourly, Saturday and Sunday, right? I will try to do the classes on the work day as well, like Monday, Tuesday, Wednesday, but our regular classes will be on the Saturday and Sunday. Got it? So in future, I will also discuss the exam taking strategies, particularly how to approach NBMEs and how to approach the NBMEs and how to increase the NBME. These are exam taking strategies like study techniques, different effective study hours, Pomodoro techniques. So I will focus on that things in future. U-world solving skills. So these are the future things that I will share with you. Webinars, maybe some things cover in the webinar as well, and the target NBME topics. So mainly the uh, purpose of these sessions mainly discuss the high yields topic that are highly tested, mainly the topics that are repetitively tested in the NBMEs and pre-120s. So last thing, how to improve the NBME. So I will maybe we will do a webinar or maybe this kind of the session as well. Like, so weekends mainly on the high yield topics and the system resources, mainly the first aid, UWorld and NBME. So I always encourage the people to limit your resources because too much resources will destroy you. Got Rock? Is anything clear to you?
Yeah.
Okay, thank you. So first thing is the UWorld. So the UWorld is the key thing for the exam. So I always advise the people start the UWorld from the beginning. Start the UWorld from the beginning. Take it from the system wise. Take it from the system wise. From the beginning. Like if you do the cardiovascular system, do the cardiovascular from the first aid and do the cardiovascular from the UWorld. Right? So I will discuss that how to approach the UWorld questions and NBMEs. This is not today topic, but in future I will highlight these things with you. Okay, so these are some key things. Read the last sentence first, whether it's NBME question. Okay, hello, read the last sentence first. Highlight the key information. Like everyone. I hope everyone is doing UWorld. So UWorld has an option to highlight the things with the different colors. So use these highlighters very effectively. So solving multi-layered question, right? Someone.
I think people need to mute their microphone because it's disturbing.
Okay, the solving the multi-layered question. So this is another thing that we will discuss in the future, right? So I will give the example of the multi-layered question in our discussion as well, because the real exam question, some NBME, mainly the UWorld question are the multi-layered. First, you are unsure about the diagnose, right? And they ask about this is diagnosed. So you are unsure about the diagnose and you have to treat that patient. So what is the drug of choice and what is the mechanism of these drugs? These are the multi-layered approach. Okay. So any question regarding these high yield course of step 1? Hello? Rock? Do you have any question?
I think it's...
Hello?
Yes, I was saying that I think it is clear.
Okay, so everybody is clear what I am saying. I try to record the sessions in future and I will try to upload a platform like Patreon and other storage platform. So it for easier to review this session. If someone is unable to join that, I will try my level best. Right?
Okay.
Okay. please communicate with me. So I think that I'm talking to the wall. So please communicate with me. Okay. So I'm going to start the introductory session today from the cardiovascular system, right? So main things. Wait a minute. Okay. So today our session from the cardiovascular system. So this is basically the heart, the car is the first organ that develops, and it's beat at the 4 week of. There is no rocket science behind this, right? So I am highlighting the high yield stuff during my session. So what is the high yield stuff in this? So the heart is the primary heart tube loops to establish left and right polarity begins in the 4 week of development. So you world and NBME ask you the question about this, the Carter syndrome. Mark it as a super high yield. So UWorld and NBME doesn't ask you in a state fashion. They give you the clinical vignette. 30-year males comes with the infertility, recurrent respiratory tract infections, right? And hello. So
Yes,
you
yes,
will
okay.
okay. So you will give you the vignette, and they give you the option the situs inversus. Can anybody tell me the what is the situs inversus? Situs inversus.
Placement of the organs according to the normal position.
Okay, so it's a placement of the vista or the organ in the abnormal side. Like if the heart, what is the normal location of the heart? Is the right side or the left side organ?
Left side of the body.
The left side.
So what happened in the Carter syndrome? The heart is on the
Right side.
right
Right
side. So
side.
this is a broad terminology, is the situs inversus, right? But
Yes.
what is the presence of the heart on the right side? Is called dextrocardia. What is called
Dextrocardia.
dextrocardia? So they doesn't ask the question in this manner. So they give you the explain this scenario in the 10 lines, 11 sentences, and they ask you which thing is it defective in this patient. So what thing is it defective in this patient? What thing is it defective in this patient? Carter syndrome.
Ciliary dyskinesia.
Defect in the left and right dining arm.
Okay, so right, it's a dynin. So it's a dynin. Right.
Dynin, okay.
So this is a simple question. They move another thing. So what is the function of the dynin? Can anybody tell me? NBME UWorld Free 120 ask in this way. Give you the whole scenario and asking what is the function of the dynin? Can anybody tell me what is the function of the dynin? It is a microtubule. So what is the function of the dynin? Can anybody tell me? Okay, they are helpful in transport. What transport? Retrograde or anterograde? So more precise, which transport? Retrograde or anterograde? You are right, they are helpful in the transport. Okay, so the retrograde, what is the retrograde transport and why it's a significance? Give me the clinical significance. This is a real USMLE. So high yield stuff, linking the basic embryology to the clinical. Okay, from axon to the cell body. Okay, right. From axon to the cell body. So retrograde, right. So what is the significance? What is the clinical significance of this retrograde transport? I am asking about the clinical significance. Here is this thing correlate with the embryology, correlate with the pathology correlate with the microbiology. So and biochemistry overlap as well. So this is a super high yield thing, and they asking this kind of thing in the USMLE step. Does it make some sense to you?
Yes.
Yes. So please think what I am. So application of the knowledge is a USMLE. So apply your basic knowledge to the problem. Okay. So the dynein involved in the retrograde transport mean exon to the cell body. So what is the clinical significance? One is if the dynein is defective, so that this transport does not take place, it will manifest as a Cartagena syndrome, right? So patient present with the male, particularly infertility, recurrent respiratory tract infection. So they give you this kind of the scenario. So next thing, retrograde transport. This is important for herpes simplex virus, rabies, Clostridium tetani. Hello? No, Clostridium tetani.
Yes, yes.
Okay, one more thing. I built the. So what is the function of the kinesin? Kinesin. Are you with me? Are you with me? Are you with me? Kinesin.
Yes.
Okay. So what is the function of the kinesin? Okay, anterograde transport. So again, the high yield stuff regarding to the kinesin. Kinesin involved in the anterograde transport and the reactivation. They give you the scenario of the reactivation of the herpes simplex virus, but they are asking about which thing. So the kinesin, I 100% you mark it kinesin. So here is the reactivation of herpes simplex virus involve the kinesin. These are molecular motor protein. Does it make some sense, Rock? Does it make some sense?
Yes, it does.
Okay, great. Great. Okay, so moving toward the septation of the atria. Give me a moment. I'm going to raise this stuff. Okay, how to raise this stuff? Okay. So septation of the atria. Just focus on this picture. I'm explaining this picture for you. Just so overlapping things are important one. So this is septum primum, right? And this is endocardial cushion, right? So this septum primum and the space between the endocardial cushion is a ostium primum. So the primum is an opening. So the ostium primum is in between. Ostium primum is in between which structures? Can anybody repeat it? Ostium primum.
Between septum primum and the endocardial cushion.
Exactly. Right. So in the second step, ostium scandum. So ostium scandum develop in the septum primum. So the ostium scandum is present in septum
Primum.
primum. So
Septum
making these things clear. So the ostium scandum is present in this green color is a septum primum. This green color is a septum primum. So the ostium scandum secondary opening is present in septum primum. Okay. So next thing is a septum secundum. Septum is another spandum, another septum. This is a secondary septum that is shown in the blue color. So this is developed right side to the septum primum, right? So the septum primum grows, and there is a foramen. There is a foramen in between septum secundum and septum primum. This foramen is a super high yield. What is the name of this foramen?
Foramen ovale.
I will tell you the significance of this foramen. right? Okay, so again in the this picture shows as a degenerating of the septum primum and foramen ovale closed. Okay, does it make some sense to you?
Yes.
So what happened after the birth? After the birth, what happened? So the left atrial pressure increase. Why the left atrial pressure increase at birth? Because we inhale, lungs expand. So these things lead to the left atrial pressure, increase in the left atrial pressure, because the pulmonary veins preload comes in the left atrium through pulmonary veins, right? So the lungs are not functional in the during
Hello?
fetal life.
Yeah, message as soon as you're available.
Okay. So at birth,
Hello?
hello, do you want to ask a question, please? Hello?
Yes, hello.
Okay, I can hear you. Doctor, do you have any question?
No.
Okay. So at birth, what happened? Septum primum closes again. Septum primum closes against the septum secundum, right? So if these, remember this concept, septum primum and septum secundum, if they fuse together, so this lead to the closing of the foramen ovale, right? So it will confuse you from the atrial septal defect. You have to differentiate the atrial septal defect from the patent foramen ovale, right? If the septum secundum and the septum primum doesn't fuse, it will lead to the patent foramen ovale, right?
Correct.
And their fusion lead to the septum. But the atrial septal defect is mainly in the defect in the ostium, in the septum secundum, right?
Yeah.
So the atrial septal defect is not due to the fusion defect due to the septum secundum and septum primum. It is basically the defect in the septum secundum, while the patent foramen ovale is a defect due to the failure to fuse of the septum secundum and septum primum. Okay. Everybody clear about this concept? Patent foramen ovale and atrial septal defect. Hello?
Yes.
Yeah.
Okay. So what happened? I am drawing another picture. So this is, let's suppose, this is the right atrium. This is a left atrium. This is the right ventricle. This is left ventricle. So if their patent foramen ovale remain patent, so what happened? So lungs are not functioning. Lungs are not functioning, right? During fetal life, lungs are not functioning. So if this if this defect is present, like atrial septal defect, so what happened? So the atrial septal defect is right to left shunt or left to right shunt?
That'll be right to left.
Right to left atrial septal defect. Are you sure?
This is after birth, you mean?
After birth, so then.
Yes.
Yeah, after birth and left.
If it's after birth, it's from left to right.
Left to right.
Yes,
Yes.
but if
Right.
it's intrauterine, it will be the reverse.
Yes, yes, you are absolutely right. You are absolutely right. So what happened? So if it is intrauterine life, so it is a right to left shunt,
Left.
right? So it's if it is after birth, so it is the left to right shunt. Which shunt lead to cyanosis? Which shunt leads to cyanosis?
right to left shunt.
Right to left.
Yes, right to left shunt, because the deoxygenated blood bypass the lungs, right?
The lung, yes.
And left to right shunt does not lead to the cyanosis, right? On the basis of this concept, we divided the congenital heart disease into the two types: cyanotic congenital heart disease and acyanotic congenital heart disease, right? So any disease that lead to the right to left shunt lead to the cyanosis, right? And any disease that lead to the left to right shunt doesn't lead cyanosis. But in the progression of the acyanotic disease, left to right shunt, after the advanced stage, they lead to the cyanosis through a syndrome called Eisenmenger syndrome. Okay, I will discuss these things in detail. So I am focusing on the thing that how this embryology correlate with the pathology, correlate with congenital anomalies. So, right? So the patent foramen avail. This is, can anybody read the patent foramen avail? This is the most super high yield stuff that is highly repeated in the UWorld and NBME. Can anybody read the patent foramen avail for me? Rock?
Yeah.
Can you read the patent foramen avail for me?
Okay, sure. So basically, it's failure of the septum primum and septum secundum to fuse after birth. And it's seen in 25% of population. Most are asymptomatic and remain undetected. It can also lead to a paradoxical emboli, which is the venous thromboemboli entering the systemic arterial circulation through right to left shunt, and as can occur in atrial septal defect.
Okay, so one more thing, the important, the paradoxical emboli, again the high yield stuff. So the paradoxical emboli, what is a paradoxical emboli? Because there is a pathology,
Yes.
there is a pathology, there is a pathology, there is a communication, like this is, let's suppose this is a communication between right atrium and left atrium. So if the vena cavas, they come the blood, and this emboli comes from right atrium to the left atrium. So it's bypassing the pulmonary circulation, and the emboli come directly into the systemic circulation. So the pulmonary circulation has a protective effect. Pulmonary circulation degenerate the small thrombi, small emboli. How can it degenerate? There is a mechanism I will discuss mainly shortly. So the alveolar macrophages and the capillaries, so the tiny capillaries of the pulmonary circulation trap the thrombus or emboli, right? And then the alveolar macrophages degenerate this emboli. And another things, endothelial lining of the pulmonary artery also release some substances that dissolve that emboli. So if you are bypassing the pulmonary circulation, there is an increased risk of the emboli, right? Does it make some sense to you? How the risk of the emboli increase in the patent foramen avail? And same thing, patent foramen avail, whether is a ASD, emboli risk also increase in ASD, right?
Yes.
One more thing, does infective endocarditis increase the risk of the emboli or? I'm asking.
Can you repeat that?
Can you repeat, please? Does infective endocarditis increase the risk of the emboli or not? I'm asking a question to you.
I think yes, it should.
Yes.
Sorry?
Yes, it does.
Yes, it does. Yes, it does. So the infective endocarditis increase the risk of the septic emboli. Septic emboli. While patent foramen avail risk the paradoxical emboli. Septic emboli. So my teaching style and my learning style is to comparative the different things like septic emboli and paradoxical emboli and the what conditions septic emboli mainly in the infective endocarditis. We will discuss the infective endocarditis in the future session. So infective endocarditis again the super high yield stuff. Should we move to the next thing? Are we any question regarding these things? Hello?
Can you explain about the embryological of ESD and patent foramen ovale? Because now I'm confused a little bit.
Okay, so you are asking about the paradoxical emboli?
No, not about the paradoxical emboli, about embryological defect in patent foramen ovale and ESD.
Okay, okay, okay. I will highlight. Okay, so wait. So ASD and PFO. So this is known as a patent foramen ovale. So the patent foramen ovale is basically the fusion defect. What is a defect? It is a fusion defect. Fusion defect of the septum primum and the septum secundum. Septum primum and the septum secundum. While the atrial septal defect is basically the defect in the septum secundum mainly. Right?
Okay, excellent. Now I understand it. Yes.
Okay. I think we should move to the next one. Does anybody has a question regarding these things? No?
I think we can move.
Okay, so again, so focus on the picture. All the picture in the first aid again, they are high yield stuff because a USMLE asking like to question in the curves and the picture based, right? So I am focusing on the picture mainly. So in the ventricle, so what happened? The ventricle septum. So first, this is muscular ventricle septum. This one, this is muscular ventricle septum, and this is atrioventricular canal, and this is the atrioventricular foramen in between the atrioventricular canal. So the high yield stuff is the pathology, congenital anomalies. I highlighting these stuffs for you. Okay, so next step is a atricopulmonary septum. Atricopulmonary. This is atricopulmonary septum. So the atricopulmonary septum arises from the neural crest cells. Arises from neural crest cells. If there is a failure of the migration of the neural crest cell, so what happened? This atricopulmonary septum does not form, right? So correlate this thing from the neural crest cells. Okay. So the atricopulmonary septum rotate. Sorry, Asma. What do you have any question, Asma?
No, you said if there is defect in neural crest, there will be defect in aorticopulmonary septum migration, and this lead to truncus arteriosus.
Okay, I am talking that if there is a failure of the neural crest cells, so this septum doesn't form, atricopulmonary septum, right? So this atricopulmonary septum rotate and fuse this muscular septum, right? So when this atricopulmonary septum fuses with the muscular ventricle septum, it form membranous interventricular septum, and this is again the high yield stuff. So the VSD is the most common congenital cardiac anomaly, and it's usually occur in the membranous portion. So if the atricopulmonary septum does not form or it does not fuse with the muscular ventricle septum, it will lead to the which pathology? VSD,
USD.
right?
Yes.
So next more important thing. So the growth of the endocardial cushion separate atria from the ventricle and contribute to the atrial septation and membranous portion of the interventricular septum. Okay, so always try to remember the pathology. If VSD, so what happened? What process is defective? If they are asking about the VSD, so they are asking about where is the pathology lies? Where is the problem? The problem is the defective migration of the neural crest cells. If the neural crest migration is not in the your answers, then check about the atricopulmonary septum. If the atricopulmonary septum not present in your answer, check about the fusion of the atricopulmonary septum with the membranous anteventricular septum. So they are asking the question in the different way, right? Hello?
Yes,
Yes.
right.
Okay. So this is a basically the thing that you have to cram. You have to cram. So I will help you how to cram it and digest it easily. So I helping the thing how to digest this stuff. So the neural crest cell migration problem. So what it will lead to? Atricopulmonary septum. So the atricopulmonary septum give rise to aorta and pulmonary trunk. Aorta and pulmonary trunk. You have to cram the derivatives. One more thing. If the neural crest cells migration does not take place, so it will lead to these. Okay. So the outflow tract formation is important. Neural crest cell migration. This migration lead to the formation of this septum. This septum lead to the ascending aorta and the pulmonary trunk, right? So if these migration of the neural crest cell does not take place, it will lead to the pathology of the transposition of the great arteries, tetralogy of Fallot, persistent truncus arteriosus. So what happened in the persistent truncus arteriosus? So the formation of this septum does not take place. So this septum does not take place. So they ask you the pathology, give you the they give you the pathology like persistent truncus arteriosus. So what is the cause of the persistent truncus arteriosus? So there is no formation of this septum. Atricopulmonary septum does not take place in persistent truncus arteriosus. So what is next is the tetralogy of Fallot. So the tetralogy of Fallot is a consist of the 4 pathologies, 4 things. We will discuss these things in the next sessions. So the embryological cause of the tetralogy of Fallot is displacement. So the displacement of this infundibular displacement of the ventricle septum particularly does not take place. So they ask you the what cause? So displacement failure. In tetralogy of Fallot, what is a pathology? Displacement failure of the infundibular septum, right?
Yes.
And what is the pathology behind the transposition of the great arteries? So the pathology behind the transposition of the great artery is this septum is formed, atricopulmonary septum formed, but this septum does not spiral and fuse. So if the spiraling of this atricopulmonary septum does not take place, it will lead to the transposition of great arteries. So they give you in the exam, UWorld, NBME, and the real exam, they give you the clinical vignette regarding the transposition of the great artery, tetralogy of Fallot, and persistent truncus arteriosus. And they try to ask you about the embryology embryological problem, right? Hello?
Yes, it's true. Yes, it's true.
Yes,
Correct.
yes.
Okay, so the valve development. So this is basically some sort of the reading section, some sort of you have to remember that aortic and pulmonary valve develop from the outflow tract of the endocardial cushion. Aortic and pulmonary derive from the outflow tract of the endocardial cushion, and the mitral and trachea derive from the atrioventricular canal of the endocardial cushion. So one more thing, can anybody tell me what is the Epstein anomaly? Epstein anomaly, and it associated with which drug? Epstein anomaly.
Lithium.
Exactly. This is again the high yield stuff. So I am concluding my session here. Hello?
Yes, yes, we can hear you.
I'm concluding my session here, and we will meet tomorrow.